Welcome to everybody who has joined us either live tonight or is joining us online on YouTube and watching the recording. Today we have Geriatrics Part 1 with Dr. Anna Haber, who will be teaching us all we need to know about Geries for our upcoming finals. If you are watching this live, please scan the QR code that is on the screen at the moment, and this will take you to our live poll and you can interact with the SBAs as they come up through the session. If you are either watching this live or online, please fill out the feedback form that is either at the end of the presentation or in the description box on YouTube, and this will give you access to the slides once you've filled out the feedback form. And just be aware that once you submit the feedback form, the link does appear immediately, so it might be best to fill that out on a phone, not on a phone, on a computer, so that you can download that presentation. And without further ado, I will hand over to Dr. Anna Haber.
Hi, my name's Anna. I'm a SE4 Reg in Jerry's at Ealing Hospital. Although this is a massive topic, I'm going to teach you what I think are not just everything that you need to know about passing your exams, but also the things that I found more useful as well for practical application on dementia and delirium. On the wards as a junior doctor. So we'll start with a case study. Mr. B, he's a 78-year-old man. Mr. B lives alone in a flat. He's got background history of hypertension, type 2 diabetes, and he takes ramipril and metformin for those. He's brought to the GP by his daughter. Concerned about his memory, she says her father has always been very independent, but has been recently forgetting to pay the energy bills and take out his bins. A couple of occasions she's visited him and found the gas has been left on. Mr. B insists he's absolutely fine. He's got no insight into any of this, and he thinks this is all part of just getting older. We'll start with a multiple choice question. So how would you first investigate? What would you do first? Would you do the AMTS? Would you request a CT head, blood tests, including full blood count, or confusion screen, or the mini cog, or refer him to a secondary care memory clinic? So you can use the poll app. Give it a few minutes, or a second. In the interest of time, we won't let it go too long because we'll get through some of the other questions first. All right, Misha, do you think that's probably enough time?
Yep, and hopefully you can now see the results.
Not as, oh, maybe it's somewhere else. No, I can't see the result, but
that's fine. So we've got the most responses for option E.
Okay, right. Well, the answer is D, and I will tell you why. So, yes, you need to refer these patients to memory clinic. However, you have to do some really brief stuff first, because just referring a patient to a memory clinic, you will drive people insane if you haven't done just the basics. Just like if you're referring someone to ED or to respiratory, you wouldn't not listen to their chest. You wouldn't refer to cardiology without an ECG, or ortho without an X-ray. You wouldn't refer to the memory clinic without doing some basic cognitive screening. So take a history, and definitely take a collateral if that is available, and then use a brief cognitive instrument to do some testing, and this list is from the NICE guidance. These are the validated scores. The mini cog is one of those scores. You don't need to know off by heart how to do it. You just need to know what the the validated scores are, and that you need to use them. And obviously you don't rule out just because they have a normal score. If you're really worried, you can say, I've done the mini cog, it's normal, but I suspect from the history that there is a history of dementia. You obviously also do a physical exam and blood and urine tests to rule out reversible causes of cognitive decline. So it's I've listed delirium, depression, sensory impairment, medication related, but there are obviously other reversible causes as well, like B12 folate deficiency. So you would do what you would know as a confusion screen, and I've not gone into that here. Then you refer to a memory clinic. If they have a rapidly progressive dementia, NICE guidance actually says referring to neurology because these people will need probably CSF analysis relatively rapidly and access to specialist testing centres. So there are many types of dementia, over 200. The most common is Alzheimer's disease. There's dementia with Lewy bodies, vascular dementia, fronto-temporal dementia, and mixed dementia is very common. So we'll start with looking at Alzheimer's disease. It's the most common cause of dementia. It is caused, we don't really understand a lot about the pathophysiology, but we know that there is an accumulation of abnormal proteins, we call them amyloid plaques and tau tangles, that lead to cognitive dysfunction. So in Alzheimer's, the primary cardinal symptom is memory loss. So not only is it the first symptom, but it is almost universal. Then there is also language difficulties and executive dysfunction. There can also be psychiatric symptoms, and also as a result of these, difficulties in performing activities of daily living, like taking care of yourself. There's a genetic component, especially in early onset Alzheimer's disease. So there are in the sort of earlier onset, there are the three proteins that have been implicated: amyloid precursor protein, presenilin 1 and 2. And then this has been getting quite a lot of publicity lately, especially on Instagram or social media, with celebrities announcing that they have this allele, and therefore they're going to be sort of giving up acting or whatever it is that he said. So ApoE on chromosome 19. So if you've got a heterozygous copy of ApoE4, which is the risky mutation, so you've got a 3 times relative risk of developing Alzheimer's disease, and if you're homozygous, you've got 8 times. But this isn't true across all ethnicities, and even in white patients, who we know that this is the most common, 50% of patients with Alzheimer's disease don't carry ApoE4. So it's not only are you not guaranteed to develop Alzheimer's if you have ApoE4, you also can get Alzheimer's without it. So how do you manage Alzheimer's disease? So I'm going to talk about, for each of the dementias, I'm going to talk about the pharmacological management when I talk about each one. But it's important to know that there's very little evidence for significant benefit in any of the medications for any of Alzheimer's disease, any dementia subtypes. So at the end, I'm going to talk about the global management of dementia. But the primary pharmacological management is acetylcholinesterase inhibitors for mild to moderate dementia, which can slow the progression of the disease. I mean, it's more in the matter of small years, 6 to 12 months, rather than having a significant benefit, but there is a proven benefit. And so that's things like donepezil, galantamine and rivastigmine, but they do have side effects. So if people who have intolerance to acetylcholinesterase inhibitors or a contraindication, then you can use memantine, and you also use memantine for severe Alzheimer's disease. It's a progressive illness, and we know that it gets worse with time. So let's do another single best answer. I'm sorry, I'm moving very quickly. There's just so much to get through. So we've got a 68-year-old male who's Mr. Babbage. He's noticed he's become a little bit unsteady over the past 2 years and he's fallen a couple of times. He finds it hard to focus. He's become forgetful. His wife has been concerned by his forgetfulness. He's forgotten things like locking the car up, turning the tap off after washing his hands. He gets defensive and aggressive at work when the mistakes he's made are brought up. So his past medical history is hypertension, type 2 diabetes, hypercholesterolemia and ischemic heart disease. So what is the most likely appropriate treatment for his likely diagnosis? So I say most likely because, again, dementia is difficult, but we go with the most likely diagnosis and then the most likely treatment. So these are difficult questions, but you need to choose the most appropriate answer. A is clopidogrel, statin. B is donepezil. C is an atypical antipsychotic. D, review diabetes medication, and E doesn't need any treatment. Right. Oh, I think I can see it now.
Perfect. So we've got the most common answer is A.
Right. Yeah, so that's correct. And why is it A? Because this gentleman is most likely to have vascular dementia. So vascular dementia is 5 to 10% of people with dementia when it occurs by itself, but it's much more common as part of mixed dementia, specifically with Alzheimer's disease. And it's also, as you can imagine, becoming more and more common as cardiovascular disease becomes more a higher burden of disease in our society. So vascular dementia is dementia in the context of imaging. Gold standard is MRI, confirming either recent stroke or accumulated vascular changes whose severity and pattern are consistent with what we can see in cognitive testing, and in the absence of any other factors. Otherwise, we would call it a mixed dementia. So there's often vascular risk factors. In fact, there's almost always vascular risk factors like strokes, vascular disease, ischemic heart disease, peripheral vascular disease. You will probably have heard that it is typically a stepwise decline, and that's usually because of sort of a series of ischemic events, although it can be a progressive decline as the burden of small vessel disease gradually accumulates. Memory is preserved initially, which differentiates it from Alzheimer's dementia, where memory is the first thing to go. You lose executive and motor function first, and then it's associated with behavioural changes. And importantly, you don't manage it like you manage Alzheimer's disease because it's not the same pathophysiology, which is a deficiency of acetylcholine. So you manage the vascular disease itself to minimise the clinical progression, and that's why we've talked about clopidogrel and statins. And I've said that's why it's most likely, because you would only use clopidogrel if there was evidence of ischemic cerebrovascular disease. You wouldn't just put someone on clopidogrel sort of as primary prevention. So I mean, it might be more reasonable to put them on a statin if you can see evidence of elevated lipids, but you really do need to see MRI evidence of strokes, not even necessarily small vessel disease. And then you would use the acetylcholinesterase inhibitors if there is evidence of Alzheimer's disease as well. And we treat the associated features. So if there is an associated depression, we might use an SSRI to treat that. So the next dementia subtype I'm going to talk about is dementia with Lewy bodies. So this is a little bit more common, although usually it appears on its own. 10 to 15% of all those with dementia. So there are two subtypes, and they are definitely separate and get treated separately. So one of them is Parkinson's disease dementia, and that is where someone has Parkinson's disease. Usually, if there's any question about which is which, you go usually by either established disease course or disease symptoms for a year, and then you get the dementia. Not everyone with Parkinson's gets dementia, but the risk is significantly increased. And then the second type is dementia with Lewy bodies. So that's where you get the cognitive changes, which are specific changes. Can be in the absence of Parkinsonian symptoms, but unlikely. But the dementia comes first. So the pathophysiology of DLB is deposition again of abnormal proteins, but these ones are alpha-synuclein, and we call those Lewy bodies. So you can see those in biopsies of the affected brain tissue, which are obviously done post-mortem. So there are diagnostic criteria to diagnose dementia with Lewy bodies. I haven't gone through all of them because they're incredibly complicated, but it's really important to look at the clinical features. So it's a fluctuating cognition with pronounced variation. The visual hallucinations are also very typical, and they are specifically very well formed and detailed. Animals, for instance, are very common to have hallucinations of dogs and similar. And then there is the associated disturbances in sleep, so REM sleep behavioural disorder, which may well come before the cognitive decline, and can often be the earliest symptom. And then there's the Parkinsonian features. So Parkinsonism is characterised by bradykinesia, tremor and rigidity. So you don't need to have all of them, and you don't need to have any Parkinsonian features at all, but having two of these is sufficient to diagnose probable DLB. All of these dementia syndromes are clinical diagnoses. The imaging is helpful, but we don't have 100% criteria to diagnose these because the biopsies obviously happen post-mortem. And then the supportive clinical features is severe reactions to antipsychotic agents, postural instability and autonomic dysfunction, which also comes along with Parkinson's disease, and then the psychological symptoms. There are specific imaging biomarkers and sleep study markers, but specifically it's going to be a clinical diagnosis. And the pharmacological treatment, although there's much less evidence, is the same as with Alzheimer's disease. So you use acetylcholinesterase inhibitors. It's really important to use antipsychotics, which some people do, the second generation antipsychotics like risperidone and olanzapine, but it is important to use those very, very carefully. And haloperidol is contraindicated with both Parkinson's disease and dementia with Lewy bodies, as they can worsen motor symptoms and cause significant side effects, including neuroleptic malignant syndrome, which is potentially life-threatening. I think it's important to look at the differences between the major dementia syndromes. Vascular dementia is often diagnosed associated with imaging, but Alzheimer's disease and dementia with Lewy bodies is more difficult, so it's important to differentiate them. Memory loss is the big one. So earlier, so the first line should have said early Alzheimer's disease. So if the memory loss is more prominent and first, it's more likely to be Alzheimer's, whereas movement symptoms are more associated with dementia with Lewy bodies. And it's the hallucinations and real fluctuation in cognitive state that is associated with dementia with Lewy bodies. REM sleep disorder is more common in dementia with Lewy bodies, and as are autonomic symptoms. moving right along, let's look at another single best answer question. A woman phones her GP wanting advice about her 55-year-old husband, who's refused to attend, so she's calling the GP. Last few months, he's become increasingly irritable and out of character. 2 weeks ago, he lost his job for repeatedly missing deadlines. He stopped taking care of himself, he wears dirty clothes frequently, and he neglects his personal hygiene. He's previously been fit and well. Concerningly, his mother died at an early age of dementia. So, providing you can get him to come in to consent, what would be the most useful test in establishing a diagnosis? So let's see if anyone's brave enough. This is a difficult one to select an answer. You think about the most likely dementia syndrome and some of the typical features of that syndrome. Give it another minute or so. All right. So I can see that people have chosen B most commonly. So I agree that B CT head would be the most a useful initial test, especially if you're a GP practice or coming into the emergency department, but the gold standard is an MRI. And the reason that we look at these is to look for frontotemporal dementia, so the typical frontotemporal atrophy that comes with frontotemporal dementia. So it's rare, it's 5% of dementia. Patients that suffer from it are typically younger. There are familial links, and again, it's abnormal protein deposition, as with most types of dementia. There are 2 main types, behavioural variant FTD and primary progressive aphasia. And primary progressive aphasia has several different subtypes as well. So I'm going to just talk about the behavioural variant FTD because it's the one that you're going to have questions asked. Nobody's going to ask you questions about any of the others, and they've only recently been sort of separated out, so it's all very new. Unfortunately, frontotemporal dementia can be one of the most distressing. It's youngest predilection in patients, and unfortunately there are no specific pharmacological treatment options. So NICE guidance actually says don't offer acetylcholinesterase inhibitors on one-mountain. So it's not just that there's no evidence. Looking through the guidance doesn't actually say why not to offer them, but it is clear that that we don't treat these medically, we treat them non-pharmacologically with supportive care. So the symptoms are, there's many, and I've listed some of them here. It's a heavy slide, but it's if you can imagine frontal atrophy, then it's the sort of deficiencies in executive function, reduced empathy, inappropriate behaviour, changes in executive function, so difficulty with planning or organising and decision making. And really typically, and that was brought up in the SBA, there is a lack of insight into the deficit. So really think about that. If there is someone with really pronounced deficits that has absolutely no insight into it, people with Alzheimer's disease typically know that they're getting muddled, at least in early stages, and similarly in vascular dementia, although it's more common to have a lack of insight there, but in frontotemporal dementia, it will be very striking that their behaviour will be really inappropriate and they will not understand that. Right, so let's talk about imaging. In all dementias, MRI is gold standard for imaging. It's generally used in secondary care in memory clinics, is far from diagnostic. It is more suggestive, but it is part of our guidance that we should be using it unless it's very, very clear what the subtype is. It also helps us rule out reversible causes of cognitive decline, like cerebral infections, like malignancy. So like I've said, frontotemporal dementia shows progressive atrophy in the frontal and temporal lobes, or both. Alzheimer's disease is specifically temporal atrophy, or hippocampal atrophy, or insular or hippocampal hyperintensity, and there it can be this gyro hyperintense band. Vascular dementia, I mean, as you would expect, shows confluent white matter and irregular periventricular hyperintensity. So that is a very fancy way of saying small vessel disease. So if you ever see a CT head or an MRI head that says small vessel disease, typically it will be these periventricular hyperintensities. There will be evidence of basal ganglia or thalamic foci, and obviously evidence of either small or large vessel infarctions. So, you know, if you've got a big MCA infarct, you would be much more concerned for the development of vascular dementia. So it's really important to talk about the non-pharmacological management here, because it's really the mainstay of treatment for dementia, and it's the mainstay of treatment for most things for a geriatrician, because when you are older and more frail, and you have more complex care needs, most of your the medications that you're being given are to be treating specific conditions. They don't treat the frailty syndrome itself. They don't, most of the time, don't improve quality of life. It is the MDT, non-pharmacological approach, that has the most effects positively in these frail elderly patients, and dementia management is no exception. So we need an MDT approach with patient-centered focus. So by MDT, I mean people like occupational therapists, physiotherapists, speech and language therapists, psychologists, and elderly care psychiatrists. The list goes on, but there is a very, very large MDT, and it should be focused around a single name practitioner. So that doesn't have to be a geriatrician. We have very good GPs that coordinate MDTs for frail elderly patients and for patients with dementia. I went to a nursing home MDT earlier on today that is run by a very capable GP. So ideally, individual needs should be assessed face to face. Now, that's obviously been a problem in the pandemic, and I've been seeing increasing presentations to hospital on deliriums on the background of previously undiagnosed cognitive impairment. And when we speak to the family, they say, well, you know, this patient has been getting more and more isolated in the community, and we know they've probably been getting more confused and more muddled and losing their memory, but we just haven't. We haven't been able to get them in to see a GP, or the patient's been really worried about coming out. They've been socially isolated because of the pandemic. Families and carers should ideally be involved at almost every stage, especially as patients' dementia becomes more and more severe. Not only to support the patient, but and to encourage advanced care planning, which is the last point, but also because they are the most appropriate people to be involved once the patient loses the ability to make decisions on their own behalf. There should be a specific care and support plan which should be regularly revisited to see how those goals are being achieved, and advanced care planning should be starting at diagnosis and revisited at each and every interaction with social and healthcare personnel. So moving on, let's talk about Mrs. M, who is an 83-year-old woman. As you can see, she is looking quite sprightly with her cane. She has a background history of hypertension, ischemic heart disease, arthritis, hypercholesterolemia, hypothyroidism, type 2 diabetes, and reflux disease. She's on a series of medications to treat those. She's got no allergies. She lives alone. She's independently mobile with a stick. She has a once-a-day package of care to help with dressing. She gets meals on wheels. Her family visit regularly and take her out occasionally, but since COVID, she hasn't gone out very much. And this is a story that I hear, as I said, quite a lot. She's a non-smoker, non-drinker, and unfortunately, she's brought into the emergency department with a fall. She's been found by her family on the floor, and they weren't able to get her up, so they called an ambulance. This is going to be a slightly more in-depth case study. So you take a history from the daughter because you can't take from the patient. She is confused and appears very distressed. Her daughter says they speak regularly on the phone. Yesterday, she was complaining of urinary symptoms and some abdominal pain. So her daughter decided to visit her with a little care package, but found the patient on the floor next to the bed, confused and appeared to be in pain, couldn't mobilise, so called 999. They're not usually concerned with her memory or her cognition, but she has gotten more frail since her husband died a few years ago, more isolated since COVID. In the house, she's independent, but she does get pain from the osteoarthritis in the knees. And her daughter is asking you, why is she so confused? What's going on? So you assess her as a good F1 in the ED or on the clerking team. She's distressed, she's in pain, and all she's saying is help me. But when you try to examine her and you try to help her, she pushes you away, and she's picking at the sheets when you try to talk to her. Her observations are as you can see, so blood pressure's a little bit high, heart rate's borderline high, respiratory rate sats are fine, and she's not febrile. Her left lower limb is shortened, externally rotated, and she can't move because it's incredibly painful. She's got a clear chest, she's got normal heart sounds. She has a distended and tender abdomen, and as you examine the patient, an ED nurse comes in and inserts a catheter because they say that the bladder scan that they did has shown a urinary retention with 850 mils of urine. Her GCS is 14 because she's confused. But her eyes are open, she's alert otherwise. She's got no focal neurology and no evidence of a head injury sustained in the fall. You do her investigation. So you start at the bedside. Her sugar is 6, her ECG is okay, her urine dip shows leukocytes and nitrites, and her blood and protein in the urine dip are also positive. Her bloods are generally okay. His creatinine's a little bit high, sodium's a little bit low, CRP is a little bit high at 70, her CK's 450, a little bit high. Her calcium is okay, and so her thyroid function. Imaging shows a fractured left neck of femur, but her chest and CT head are okay. So, big case study, but this is the only case study we're going to have, I think, in this section. So how would you best assess the new confusion in this patient? And the important thing is you need to pick 2. So pick 2 and let me know what you think. Again, a difficult question, and we'll go through it because I know that there's so many of these to choose from, but you do have to pick 2 because NICE guidance only talks about 2. Right, so we've got for AT, we've got the DSM-5 criteria, almost. So NICE guidance talks about confusion assessment method and the DSM-5 criteria. Now, I'm going to talk about more. The MOCA and the RUDAS are in-depth cognitive assessment. They're not rapid screening tests. So those are obviously, or at least obviously for me, not the ones I would choose. We will talk about 418 in a second. So let's just go through her issues. So we think that her issues are probably that she's got UTI, she's got urine dip that's positive and a very CIP, although that can happen from her fractured neck of femur. She's got urinary retention, she's had a fall, she's got fractured neck of femur, she's in pain, and she's probably delirious. So before we move on to talk about delirium, I'm going to ask another question. Which of the following delirium features is most helpful in differentiating between delirium and dementia? So there are a lot of similarities between the two. Which is the most useful? Often these single best answers will have answers that you think, wait, all of these could be true, and that is often true, but you have to pick the most appropriate answer. Right. So we've said we've got most answers for disturbance and attention. That is correct. So delirium is really characterized by being a disorder of attention disturbance. Now, when you're taking the history, you may also hear other things like she's not usually like this is a definite change, and that is really important too. But it really is a disturbance in attention. So delirium has, according to the DSM-5, 4 key features. Reduced awareness, a change in cognition from baseline, a sudden onset, and they talk about evidence that there is a systemic illness or substance intoxication or withdrawal. Now, I'd like to talk a little bit more about that because often it's not always clear what the insult is, and as you can see by our vignette, there's often more than one thing. There are 2 main types, hyperactive and hypoactive. So I think it's really, really important that you guys understand that although the hyperactive is the most commonly recognised, it doesn't mean it's the most common. So hypoactive delirium is actually much, much more common. It's just incredibly under-recognised. So emergency departments cannot recognise a hypoactive delirium. So we are constantly asked to do lumbar punctures on patients who come in with a reduced level of consciousness and a fever. Yes, some of those are indicated, but so many of these people are hypoactively delirious from their infection. They do not have, although they have evidence of acute brain failure, it's not an infective intracranial infection. It is an infection causing acute brain failure, causing a delirium. And patients, perhaps because their delirium is not as well recognised, but patients with a hypoactive delirium actually have a worse prognosis than hyperactive delirium. So yes, this is about passing your exams, but it's also about taking these things with you into the future. It is very important to be aware of hypoactive delirium and how dangerous it is. And then there are mixed. So you will have patients that go from being somnolent and hard to rouse to being agitated and wandering. So what has most likely caused Mrs. M's Mrs. M's delirium? Is it A, a urinary tract infection, B, urinary retention, C, fracture, trauma, D, pain, or E, all of the above? So we won't give this one particularly long because it's more something that I've made pretty clear, I think. And yeah, exactly. So it's all of the above. So delirium is, I say very often, multifactorial. It's almost always multifactorial, although often, you know, there's a clear precipitant. Someone's come in with a UTI. The problem with emergency departments and the problem with acute medicine and with doctors in general, is there's going to be a lot of query UTI delirium, and what that means is that we don't know what's caused it. So if you're saying query UTI, you don't have significant evidence for a UTI, but you can see that the patient is delirious, but you can't, you say, oh, you know, there's not enough to put your finger on. So in these cases, they're often multiple hits, a little bit of pain, a little bit of a change in circumstances, a little bit of constipation. And why do we care about this? Why do we care about delirium? Why do we care about identifying it? For various reasons, both involving the patient and the health system at large. People who develop delirium stay longer in hospital. They are more likely to develop dementia, and they have complications in hospital, like falls. So falls for the hyperactive and pressure injuries for the hypoactive, more likely to be admitted to long-term care and more likely to die. So delirium is associated with very high morbidity and mortality. So how do we solve a problem like delirium? You start by doing a risk assessment, and you risk assess every patient. So identify patients that are older, that have cognitive impairment, that have a hip fracture, and that are severely unwell. And you take this cohort of patients. You don't ignore the others because some of them will be delirious, but you take this cohort of patients and you screen all of them. So you may, when you become junior doctors, you will see that in your clerking booklets there will be a 4AT or an AMTS or a CAM in your clerking booklets, and that's because the vast majority of the patients that you see will either have a serious illness or they'll be older, so basically everybody you see will need delirium screening. The NICE guidance talks about DSM-5 or CAM. The British Geriatric Society likes CAM and the 4AT, and I will show you why I like 4AT. So this is the DSM-5 criteria. A disturbance in attention. It develops over a short period of time. It represents an acute change. It fluctuates. There are disturbances in cognition. And then D talks about not being explained by something pre-existing. And there's no coma. And that we can see that there is as a direct physiological consequence of another medical condition, or it's multifactorial. So that's quite a lot. There's a lot of words there. CAM is more simple. So there's 4 criteria, and you can have 1 and 2. So you have to have 1 and 2, and either 3 or 4. So again, it's very, very similar. Sudden and fluctuating, inattention, which is more of a focus here, and I think is more important. Disorganized thinking, and or an associated altered level of consciousness, which can either, as we've said, be reduced or hyperactive. And then the 4AT simplifies it even further, and the reason I like it so much is because I am a med reg and I do most of my work in clinical practice. It looks at alertness, cognition, attention, and acute change or fluctuating course. It says exactly the same as all of the other ones, but it says it succinctly, and there is an easy to use form. So this form I've got from the internet. You can get it very, very quickly. You do yourself the score and you document the 4AT on your clerking. It gives you a series of points for various questions that are very, very easy. You look at the patient, you say, are they normally alert, mildly sleepy, or clearly abnormal? You ask them their age, date of birth, place, the name of the hospital or building, and the year, and you score them. And then you ask the patient, tell me the months of the year backwards, starting at December. You can prompt them once, and then you find out if it's an acute change. And if the score is 4 or above, you're more worried about delirium. 1 to 3, possible cognitive impairment, and 0, delirium or severe cognitive impairment is unlikely, but still possible, especially if we don't know whether it's new or old. So I find that really easy to understand. As you can see, the definitions of delirium remain the same across all of these scoring systems, and they are all validated. So, you know, I think you can use all of them. So when you're on the wards as a junior doctor, we've talked about admitting patients and screening them and identifying delirium, but let's talk about the management of delirium. And more importantly, when to manage delirium with medication, because you will be asked to medicate your patients. You will be asked by the nursing staff because unfortunately they are the ones that have to spend most of the time with the patient. You'll be asked by family members because it is distressing to see family members in such a different state than what they used to. And you might be asked by the patient themselves, please help me, and you will want to be able to do something quickly to medicate. So when would you medicate a patient? If they have extremely high care needs, if they have a high falls risk, if they are in distress, if they have psychological symptoms like hallucinations, delusions, or psychosis, or in all of the above situations. So I'll give you guys a few minutes because we're sort of getting towards the end. We've done well on time. Have a think. Right, so we've got the most popular answer is delusions, psychosis and hallucinations, D. But actually, if you look at the guidance, you do manage delirium in these situations only when it's causing the patient distress. So there are other situations that you would use them, as I talk about here, but in the ones that we've looked at, high care needs isn't enough. So the nursing staff, you will most commonly be asked to say, look, they're refusing to take their meds, or, you know, they're wandering up and down the ward, or they're shouting. Can you give them something to calm them down? B is a similar situation, or they're wandering. And D, you know, they're sort of agitated, they're seeing things. Really, the only one of these that's indicated is if it's causing, so for instance, their delusions or their paranoia is causing the patient significant distress, you could think about medicating. The only other reasons that you should medicate these patients is to prevent harm, either to themselves or to the caregivers, so family members or nursing staff or you, or patients in the bay. So shouting is uncomfortable and distressing, but it is not harmful. So it is not, you cannot medicate a patient to stop them from shouting. You can't medicate a patient to stop them from wandering unless you've done everything that you can to prevent falls. So that includes one-to-one, moving them to a bay where you can see, in front of the nursing station, falls alarm. There's lots and lots of things. So a high falls risk is not in itself a reason to medicate a patient. And you always consider if other forms of restraint are more appropriate if treating to prevent harm to others. So, you know, is there anything you can do to de-escalate the situation if nursing staff or patients are at risk? So if you're going to medicate, we use haloperidol, and there are lots and lots and lots of side effects. So this is a single best answer question, which is supposed to bring to light how many there are. So only one of these is not a side effect. Which one do we think it is? Yeah, that's correct. So second-degree heart block. So there are many. It is associated with ventricular arrhythmias, but most typically as a result of a long QT. And all of the others are associated with haloperidol, and there are many, many other side effects. It was sort of hard. It's actually really hard to write this question because I had to find something that it wasn't associated with, and it's associated with everything. So medication of delirium with antipsychotics or sedatives comes with significant risks, and should be approached with extreme caution. So not only is it direct drug effects like dystonic reactions, neuroleptic malignant syndrome, seizures, or long QT, but they can work too well. So you can oversedate patients, they can aspirate, they can get pressure injuries, and they don't eat, and then you need more and more invasive investigations and treatments like nasogastric tubes because of iatrogenic sedation, and they can convert hyperactive delirium to hypoactive delirium, which is actually different to oversedation. It affects the brain and it can just switch them over, and this can last far longer than the effect of the drug on the brain. So you have to think very, very carefully, and you may have to be prepared to stand your ground. And I'm not saying that I've never medicated delirium, and I'm not saying I've never used benzodiazepines, but the more senior I get, the more resistant I am to treating, and the more carefully I treat my patients. There is nothing I hate more than coming onto the ward and seeing that someone has given my patients lorazepam overnight. Although it is always very difficult when you're not there to make comment on whether or not it was necessary. So avoid benzodiazepines. They are very strongly associated with negative outcomes and high mortality rates in these patients. So how do we manage delirium? There is a really good mnemonic, which I actually stole from last year's presentation, so thank you. I like Bowles, bladder, pain, but this is fantastic. Pain, infection, nutrition, constipation, hydration, medication, and environment. Identify and eliminate reversible causes. That is the #1 cause treatment for delirium. Will it go away if you do those things? Not always. Delirium mostly goes away, but it doesn't always go away. And if it goes away, patients are often left with long-standing cognitive deficits. Now, it is not clear whether these cognitive deficits are an unmasking of a previously undiagnosed cognitive impairment, or if they are purely because of the delirium. It depends on each individual circumstance. But either way, you manage them all the same, which is that you correct the underlying cause, you optimize the patient's environment. Moving patients, so you might ask, is it better to put them in the side room or in a bay? It's wherever they're safest and wherever you can care for them the best. What is associated with high rates of delirium is not bays or side rooms, it's actually moving the patient more often. So try to not move them. Obviously light during the day, darkness at night, quiet at night. Try to minimise unnecessary medical interventions or observations at night. Try to feed the patient, try to get their family members around them as much as familiar environments as they can. And overall, you obviously need to ensure that the patient is safe and that the carers are safe. So unfortunately, sometimes that does mean using deprivation of liberty, using restraints, but that should always be as a last resort. So that brings me to the end of the talk. Thank you very much for having me. Let me know if there are any questions.
That was amazing. Thank you very much. All of the SVAs and the whole presentation was so insightful, and we're definitely looking forward to part 2 of Jerry's and seeing what else we can learn. But anyone who's joined us live or online, if you fill out the feedback form, you'll be able to get access to the slides used today, and you'll also be able to give Dr. Anna the opportunity to give her some feedback on her teaching, as that is something that everybody appreciates, especially going through training. And if that is everything, I believe we will call it a night. Thank you everybody for joining, and again, thank you Dr. Anna for teaching us about Jerry's.
Thank you. Thanks for having me.